Right. Hi again, everybody. My name is Haelle. I am the Health Beat Leader on Infectious Disease for the Association of Healthcare Journalists. AHCJ is the largest organization of healthcare journalists in the US and does not accept funding from any corporate interest, including pharmaceutical companies. This webinar is one in a series of topic trainings opportunities to brief journalists on the latest information or the latest depressing news in a particular health area, and to give you story ideas and story resources that you can use in your work. Today's topic is Trust Public Health Reporting and the CDC Insider Perspectives. And we have with us three, you can't get better insiders than this. I am incredibly grateful to our guests today. We have Deb Houry, the former Chief Medical Officer and Deputy Director for Program and Science at the CDC. Demetre Daskalakis, man, I thought I was going to do it right. Okay. Former Director of the National Center for Immunization and Respiratory Diseases, and Daniel Jernigan, the former Director of the National Center for Emerging and Zoonotic Infectious Diseases. And as you all noticed, I used the word former 3 times there because the reason we've invited these incredible public health servants here is they all chose to leave the CDC in the wake of the firing of the director. And we're going to hear about their experiences working at the CDC, their decision to leave, and their outlook on public health and in the US right now and in the future. This one will be a little bit different because we're going to start with the conversation. There's not a presentation we're going to have like we've had many past webinars. I'm going to be asking questions. While I'm asking questions, I will stop at a certain point and we'll turn to your questions. You can ask questions at any time by typing them into the Q&A space where the question mark is at the bottom of the Zoom frame. And I'll direct those to our guests. We'll probably talk for maybe 20 or 30 minutes and then we'll move to those questions. Those questions I might bounce around according to what I'm seeing there, but if that's where you can put in questions that you have. All right, so with that, we will get started. And my first question goes to all of you, which is kind of a let us know who you are. What led you to enter the field of public health? Kind of give us a brief overview why public health matters to you. And then kind of just an elevator one sentence about what your job entailed at the CDC. And we'll start with Deb.
So I was interested in public health, I think, because, I was an emergency room doc. And so I was on the front lines all the time seeing injuries and violence that could have been prevented or people presenting with end-stage cancer, and just really saw how public health and prevention was so, so important. When an opportunity arose at the CDC, I was a tenured faculty member, doing research. I jumped at it because I knew that I could take individual patients and have populations as my patient, and loved my time at the CDC. I was initially the injury center director, overseeing all the overdose, violence prevention, and mental health work. But at the time I left, I was the chief medical officer at CDC and the deputy director, which meant I oversaw almost all of the national centers at CDC, as well as the Office of Science. And I was the senior most career scientist and leader at CDC at the time of my leaving.
All right, Daniel?
Yeah, sure. So I trained in internal medicine, and while I was doing that, actually really liked the diagnostic part of medicine, but the management part, not so much. I like the figuring out part, but how can we treat your back pain this time? That was not quite as interesting. So for me, I actually had an opportunity to go to Haiti with a few other doctors, and there really saw the importance of context, of knowing kind of all the other things that are happening that impact health, and seeing how in order to change those things, you really have to take all of that into account. And so that was something that I think really stuck with me. And then during my training in medical school, I had the opportunity to work with some folks that had worked at CDC, and they talked so highly of it that I thought, oh my God, this must be either the greatest thing or their lives must have been rather dull. But it turned out that they had so much to talk about it with the Epidemic Intelligence Service and other things. And so once you get here and learn how to use science, how to drive that evidence into recommendations, you can see how close the work that we do at CDC and in public health is to the impact and the outcome. It's very proximal. It's very tangible. And so for that reason, it's a great place to be, not just focusing on the individual, but looking to see how the whole community can be improved.
Demetre?
So I was a simple HIV doctor, infectious disease trained, and started in New York City after finishing my training in Boston. And there I started doing HIV testing as well as post-exposure prophylaxis and early pre-exposure prophylaxis work, sort of targeting some of the folks who are at the highest risk for acquiring HIV, and really started public health at the most grassroots level by doing HIV testing in commercial sex venues in New York City and nightclubs, and also then started to do vaccines there as well during a meningococcal outbreak. And didn't know I was doing public health. Just thought that was part of what an ID doctor would do. And ultimately, a family donated some money to NYU to have clinicians become researchers and investigators and do other work that could potentially prevent people from dying from HIV like their son did. And so I was the recipient of that resource and was able to pursue my master's of public health, where I discovered that what I had been doing was in fact public health work. So I learned how to do that sort of more operationally and with like the sort of academic rigor. But then what I learned is I didn't know anything until I met EIS officers. And when I met people who were EIS officers and were trained in the EIS, I actually learned how to do applied public health when I became the director of the Division of HIV Prevention, or Bureau of HIV Prevention at New York City, where I get the great honor of being the first public health official to sign on to the notion that undetectable is equal to untransmissible, and also implement the Ending the HIV Epidemic program in the city and state that's responsible for driving infections in the city to the lowest they've ever been, and inspiring the Trump administration's Ending the HIV Epidemic EHE program. So I worked in HIV for a while, eventually was accelerated into disease control, where I was in fact the chief of ID for the Department of Health and Mental Hygiene, got to do some really important outbreak work in measles and in COVID-19. And then always had wanted to go to CDC. I got to give a lecture once at CDC and the Division of HIV Prevention about my work in commercial sex venues, and was like, someday I want to come here. And then I jumped at the opportunity when I was offered the job of the Division of HIV Prevention lead, and then proceeded to have a lot of jobs in CDC in the 5 years I was there, including working in the COVID response, going to the White House for a little bit to work with Dan's fabulous team for MPOX, and then back to CDC, where I was the director for the National Center for Immunization and Respiratory Diseases. And here's the one-line elevator pitch. It's the center at CDC that's responsible for a lot of the immunization work, like vaccines for children, as well as the surveillance and science behind many vaccine preventable diseases. I work really closely with Dan and at the time, John Omerman, who was the center director for HHSTP. And so we made up the triumvirate of infectious diseases with our fearless leader, Dr. Houry.
Great. It sounds like from all three of you, the CDC was sort of this this fantastic career goal and sort of peak, and it was a great place to work. How did that atmosphere shift after January 20th? What was your job like in the months between Trump's inauguration, your departure from the agency? And obviously, I'm not looking for a play-by-play, but just sort of a sense of the forest rather than the trees. I guess we can go in the same order. Deb?
It certainly changed. I was actually the transition lead for the agency, which meant, preparing, myself and all the centers, and really the overall agency for the new administration. And so what I want to say is we go through this every 4 years. And the prior Trump administration, CDC really did well in. We saw lots of new priorities and programs excel. And so we were cautiously optimistic. Unfortunately, that's not what panned out. Very quickly we saw, like during a measles outbreak, a secretary who was absent and would promote misinformation and vitamins over vaccines. The DOGE cuts came, to where they took out one day 2,500 of our staff, and really crippling a lot of the non-infectious work that was being done. More and more political appointees came to the CDC. Normally we would have 2 to 3. By the time I left, I think we were at 12, all in the office of the director. And I was the only career in the office of the director at the time I left, which is highly unusual. And that made it very difficult to do work, because this isn't political differences. These are ideologic differences. And we had a leader who did not interface with us. He never I met the secretary once when he came, which I'll get to in a sec, but he never was briefed by Dan, Demetre, or myself, or any of the senior career scientists during these things. And we are constantly being pushed, whether it was measles or vaccine safety, things that we started to think were unscientific and unethical. The shooting happened, which was devastating for CDC, a violent attack on our agency with over 500 rounds fired, 180 windows impacted. Each bullet meant for our staff really changed the demeanor, traumatized our staff. And the secretary came to visit a few days later. That's the one time I met him. He toured the facility. Later that day, he did a media interview where he said, "Don't trust the experts." That was not what we needed during that time. We needed support of the administration. Several times I had thought about resigning. In fact, April, I cleaned out my office and only had pictures on my walls and had written a resignation letter. But I stayed, in part because of the guys you see on the screen and because of the amazing staff at CDC. It got harder when they fired the vaccine committee staff. I called Susan Menares, told her I didn't think I could last until she came on board. And she said she would get there and she would change things. She arrived, tried to make some changes to the vaccine committee, and was told by the department she couldn't make any staffing or policy decisions. I knew at that time I was going to be done. I told her that. And then when she had the meeting at the department that Monday, I called Dan and Demetre afterwards and said, "This is going to be it for us." Like we had talked for the month prior around all of our different lines, but we just knew if the one person that we had any hope of, holding the line and protecting science and integrity at the agency was going to be gone, we were too. So we actually voted and walked out together.
Before I go on to Jan, I want to mention for the audience, a couple of you mentioned the EIS service. That stands for Epidemic and Intelligence Service. Those are your epidemiologists in the field who are going out, just so that other people are aware of that if they weren't familiar with that group. Daniel, go ahead.
Yeah, sure. So, like Deb mentioned, I've actually been a CDC for 31 years, or had been, and have been through multiple different administration changes, Republicans, Democrats, etc. Each one has their own characteristics. Each one has its own ideology, but the means by which they execute on those ideologies, I think that was the thing that was very different in this last Trump administration. The prior one was somewhat similar to ones that we had been in before. Once they were away, I think there was time for them to prepare with certain things. They came in, I think, with more of the high level ideas about what they wanted to do, but the execution of change was very, very different this time. We had different impacts coming from different directions. You had DOGE cutting staff, sometimes using algorithms and artificial intelligence decision making in order to figure out who to get rid of, which was not connected in with what the budget folks were trying to do in terms of cutting the dollars that were being used by the different programs. And then you had the secretary come in with a set of priorities that didn't match either the staffing that he had remaining or the dollars that had been put forward. So you had things like prevention and chronic disease prevention as an important factor, but then those programs not being available. So this disconnect between who was making different changes to the government, I've never seen that in prior administrations previously. Another thing that was very different here, I think, is how the legal approach to things was being used. For one thing, there was a lot more transactional kind of approach in this administration than previously, but there was a real sense that they would talk to the lawyers then would actually figure out how to get information. So rather than just asking the scientist about something, the lawyers would send a note saying, "This is attorney-client privilege. We want you to tell us about measles," or about whatever.
Instead of just asking you to brief them like you normally would? Did
Correct.
they think you weren't going to tell them?
I don't know exactly the reasons. I think part of it may have been that it was a way of protecting that information because it's attorney-client information. But also, it's an approach to engaging with the staff that I just had never seen before. And then for me, following on with what Deb was talking about with sort of the reasons for the for leaving, for me, I was being asked because our group had the vaccine safety data in it. We were asked to provide a lot of vaccine safety uh, data files to people that we didn't know who they were, or we did know them and we were concerned about them. And we didn't know what kinds of studies they were going to do, and we didn't know exactly how they were going to use that information. But we had the sense that these were folks that had been on the margins previously, had been brought in a position where they have authority and access, and they would be rethinking and evaluating a lot of the data for which a lot of studies had already shown no connection. For instance, thimerosal and autism. And so for me, we had to ask, is what they're asking us legal? And we got determinations from our Office of General Counsel that yes, in fact, according to the unitary executive privilege interpretation of the law, you have to give all of this information to the secretary and anyone that they identify, which in this case were contractors. And so that was apparently legal. Was it scientifically sound, which is an important question that we were asking? And we didn't know what was happening with the data. We didn't know who was really going to be doing that analysis per se. We weren't sure what study approaches they were taking. And so we couldn't answer that question. But a final question that we kept asking ourselves was, is what they are asking us ethically responsible? And so for us, we were told because of the interpretation of the law that these contractors did not have to sign a data use agreement. They didn't have to sign an assurance of confidentiality. And those are things that I make my own staff have to sign whenever they're doing the same kind of work. And so in that setting, was it legal? Yeah. Was it scientifically sound? Not quite sure. Was it ethically responsible? My sense was no, it wasn't. And I communicated that to them. But again, like Deb mentioned, we were waiting. I think Susan had been just approved, and we thought this is a chance where there will be somebody that's going to stand up against this and help us to find a path. Because it's not that we didn't want to work with them, it's just that what they were asking us was not appropriate. So for us, when Susan eventually was fired for not firing us, that was that final line for me and for all of us. And so we made that decision. And I think it's important because it allowed us to speak because we resigned. Had we stayed, I think we would have been marginalized as on administrative leave, like all the other leaders, where they really can't speak out about what's been happening.
Demetre, what can you add?
My turn. So it's hard to go at last because they've covered so much. So I'm just
Don't worry,
going
I'm gonna ask you first on the next one. Don't worry.
No, but it's okay. I'm happy to. I can. It's we. We like. I think what's really important to know is that we were communicating together about sort of when the moment comes. So I think that I have sort of very specific things that I was seeing sort of in my tenure that were very concerning. And I think the most of mine had to do with sort of the weaponization of the infrastructure around vaccines, separate from the safety issue, which I think Dan went into great detail. And so for me, I think like Deb said, we all tried to engage with like the secretary's thinking before he came to the office. And obviously that was very concerning. And I'll start by saying that my experience with the secretary before he was a secretary was him suing us at New York City Department of Health while we were trying to control a measles outbreak in Brooklyn, the one that's the biggest ever since the last one. And so suing us to not let us do the work to reach out to the community and do the work needed to actually end that outbreak. And so that was my first interaction. But then again, like what you do as a civil servant is that you try to crawl into the brains of the political folks that are coming in to be your lead, so that you can understand how to meld the science, the good public health, the good policy into their mission. And so no one was upset about hearing that we were going to make America healthy again. And nobody was upset about radical transparency and gold standard science. But what I experienced in my time under this secretary was that none of that was true. It was propaganda. It was words that didn't match actions, which I think correlates pretty closely to what Dan said. In general, there was no strategy. There were words, and then there were actions that were quite different than the words that were spoken. And so that I think is a consistent finding. For me in the vaccine space, the parts that were very concerning were learning about a change to the vaccine schedule for pregnant people and children on Twitter or on X. So being the head of the COVID unit, it's atypical that we wouldn't know something about a major change in policy. And also, any major change in vaccine policy generally requires a process. This neither had process nor were we informed until we heard it online. Again, what they say and what they do is different. They announced one thing online, told us to implement based on their video, and that's not what they wrote down. And so they said no pregnant women should get the vaccine and no healthy children online. They said healthy children and healthy pregnant women shouldn't get it. So they couldn't even get their video and their writing straight. And so these were the people that are doing fast and loose policy setting for the entire country. So then for me, that was number one. Number two, the dismissal of all 17 ACIP members who were very well-respected scientists. I just saw the former chair get an award in front of the entire infectious disease universe. I think, Tara, you were there with me to see her get that. And like just very well-balanced scientists who were replaced by folks that were only focused on ideologies to try to discredit vaccines, remove mRNA vaccines from the story, all of the things. And so, I was able to sort of figure out how to work with that still, because CDC's job is to provide the disimpassioned science for public discussion to really lead to policy. And so, when that same group of people with the support of leadership at CDC and HHS, not the political leadership, so Stuart Burns and some others at CDC, they decided to really cut CDC completely out of the process of thinking about what would be important to discuss for policy and who should be on the work groups to think about that. So the entire thing has become a zombie version of ACIP that is sort of staffed by sort of members that are ideologues and folks that are living in the work groups who really comport very closely to their vision. So when Susan was going to try to sort of work on ACIP, I had a glimmer of hope. And then when she called me and said, I'm no longer allowed to interact on the vaccine policy space without clearance from HHS or the secretary, that all of a sudden became the beginning of the ongoing beginning of the end and the accelerated end. We then got shot at like right before that, and everything accelerated. And so the sidelining of CDC scientists got more intense. And when it was clear that there was no longer scientific leadership at CDC, this is where our stories merge. And Dr. Menares looked like she was going to be removed. We made the decision to leave together because all that we could do is harm rather than good in that setting. And so again, 3 doctors, Hippocratic oath, first do no harm. They were weaponizing our agency and weaponizing us.
Hearing what you're saying, I'm impressed that you lasted as long as you did. Looking back, is there anything you would have done differently?
I guess I'm going first again. Is this my turn?
This time you get to go first.
Look at that. So I feel like, I think always like hindsight is 2020. And I think that there's definitely things, I think that one of the important things that I've learned is that the only way that we can make a difference right now is by sort of stating what is wrong. Like, this is not normal. This is not how normal science happens, and this is not how normal public health happens. That doesn't mean that there's not another way of doing public health, but this is like highly flawed. And so I think that, in retrospect, like, I worked with everyone to mitigate the harm. And that meant that I still felt that I was doing good for people. So I don't feel that I had a different moment where I would have left. I think that was the right moment to leave. But I do think that, I'm just grateful that I had a team, which is what CDC does. Like, we have a team here to really sort of think through it together. And so, I think doing the resistance that we can do by making sure that we mitigated bad decisions, I thought was the right thing. I'll be honest that in retrospect, my answer isn't about doing things for public health, but doing things for my own mental health. This was really bad for us. And not just bad for us, like at the leadership level, but bad for everyone at CDC. And I think Dan and Deb will remember that I handed out everyone a yellow ribbon because our CDC scientists were being held hostage. They continue to be. And so I feel like, maybe I should have left earlier for my mental health because it was a really hard place to work. And seeing like people who are so dedicated being attacked by people that actually just don't like them, which is what the secretary does not like CDC. So let's be clear, there's something personal about this. Seeing that every day, I think really wore on my soul. And that's what I regret, which is not thinking about my health a bit more.
Deb or Daniel, you want to jump in?
Sure. I mean, I can go. So what would we do different? Is that sort of the question here?
Yeah. Well, if anything, yeah. Like looking back, I mean, yeah, like Demetre said, hindsight's 2020. I mean, none of us has time machines, but is there anything that you wish you'd done differently?
Yeah, I think if there had been an opportunity to understand who was actually in control up there, Deb may have had more visibility of that, but there was a continually changing set of leaders up there. And the default is for you just to roll your eyes and I have no idea who's actually in charge right now at the level below the secretary. So I think there could have been, more monitoring of that and engagement there because each one of those individuals needed to be brought up to speed because they just did not have the background. And so that would have been a lot more work, but I think it would have been important to do. I also think I'm wondering if we could have done more with alternate types of documents, and that is by providing white papers to them that walked through what some other ways of doing things are. Because I think at times they moved forward with things and just handed them to us. And if there were a way to have had more dialogue, I think some individuals may have made some different decisions. Who knows? And I think it would have been great to have anticipated sort of the trajectory and really and prepared the staff a little bit better. I think the timing just wasn't there. But the real problem, I think, was the choice of not going with science as your primary driver for policy making. And if there were any way that we could have tried to mitigate that some, I think I did not fully anticipate how much the terminology of radical transparency and gold standard science would be just turned on its head. I think one statement we've been using is that the secretary has really been trying to have conclusions first and figure out things later, where somebody described that as going from evidence-based decision-making to decision-based evidence-making, which is essentially what's been happening here lately. So I don't know if we could have done anything more about that, but I was not prepared for it to be quite as in your face with that kind of disregard for the science and the scientists.
Every time one of you says radical transparency, I think of my son who's 15 because I've finally got him to start reading 1984 so he understands what double speak means.
Double speak.
I mean, it's one of the best examples of double speak. Every time an HHS press release lands in my inbox and I see that radical transparency, and I'm like, these words do not mean what you think they mean. I mean, so Deb, go ahead.
I think I would echo what Dan and Demetre both said. I think really, physical and mental health, towards the end, after I left, people were like, wow, you look so radiant now. Like you feel much more rested. It was extremely stressful, took a toll on my family. And I have thought so hard about what could we have done differently, particularly as the transition lead for the agency. But I can tell you our programs and staff were prepared. We had looked at, how publicly available our vaccine safety data was. We had, talked about preparedness. We'd looked at patents, conflicts of interest. We had done everything and above. Like, we're A+ students. So we were prepared. What we weren't prepared for is that we never got to have discussions with people in general. And I verbally offered to quit twice, once end of March and then once in April. And, it was beyond tough. I think, I probably fought and protected more than people realized, because I didn't want to tell people every day like how bad things were. But after I think the three of us left, it has become very clear to those that are left in the agency that there is like no filter or protection or line left. So I think the only thing is, should we have left sooner for our own physical and mental health? But I think if we had, you never want to give up. We're committed public servants. We were trying to do, and we had hope. We had hope that there would be an opportunity. So I don't know.
Since we're at the halfway point, I'm going to start melding together some of my questions that I had prepared that I sent you guys with questions we have coming in. And one of those is to find out where journalists and where the American people should turn for the reliable evidence-based reporting resources that we used to get at the CDC. And we know that there's been lots of changes to the website. And I'm going to pair that with a question from one of our attendees, Meryl Davids, who asked how much research universities can take over from what's now missing from the CDC. Like, are there universities that you recommend? I'm aware of the Vaccine Integrity Project that CIDRAP is doing in Minnesota. But, are there, so it's sort of a two-pronged question here. Where can people turn, and to what extent can universities step up for that? And I'll open it to you guys. I don't know which of you wants to address that.
I mean, I can start, and then
yeah, go for it.
Yeah.
So I think, so first about, there is a bit of a challenge right now because, I think, bits and pieces of the CDC sort of like website are getting a bit more suspect, like as we go forward. So I think it's hard to necessarily predict sort of where the uncertainty is going to be. I think it's fair to say that, then I think Dan will speak more to this. Like, there are certain things around vaccines that I wouldn't trust from CDC anymore. And I think that the first part of the answer is sort of thinking about, for those who have a clinician, ask your clinician in terms of what things mean and sort of where things are. I think looking at your local health department and state health department as best you can is also a pretty good source. I mean,
I live in Florida.
Yeah, there is I was going to say there is variability about what you can look at, but I think that then going to your provider and then also thinking about sources that are, trusted organizations. I'll say that one of the notable things about this secretary is that he is trying to create a wedge between doctors and their patients, and that should be a red flag for anyone. That is like exactly the thing that is bad. And so the organizations that represent them, like ACOG for OBGYNs, AAP for pediatricians, ID doctors at IDSA, everyone in the world with AMA. So like there's a whole list of organizations that are putting out recommendations that I think are helpful. And then yes, CIDRAP is a great source. They have a lot of work to do because there's so much going on, but they're a really great source for information, especially around, at this point, seasonal vaccines. But my understanding is they're also working on some of the other vaccines that will be discussed at ACIP meetings. And then where do universities fit in? And I think that the answer is, there is definitely a role for universities, I think, to step up. And I think especially, and I'll defer this one to Deb, especially in parts of the country where there's sort of like a regional effort happening to sort of create like a different way of sort of going around public health delivery. Like, I think that there's a great opportunity for universities to plug in and really be some of the all hands necessary to be able to sort of, guide us through this very complex time. CDC provides great expertise. They're not able to speak as freely as they've been able to. That's different. for some universities, realizing that there's also retribution in that space. So I think it's like more a question of like, how you can plug into these bigger systems that are forming to see where you can actually be helpful. And so I think there is a role for academics outside of CDC. And I think it's really about connecting with the organizations like local public health, state public health, to really ask the question, how can I be helpful? Because I bet you they will take you up on it. And it may be free for now, but it won't be free forever. I think when sanity sort of like returns to the world, like whatever is evolving now to address this gap is going to be the model for the future. So I'm sure Dan and Deb have other great ideas here.
Who wants to jump in? Dan.
Oh, yeah, sure. So a couple things there. This one's a tough one because I think, the people that are at CDC, there's a fair number of people that are good scientists that are, able to do the really good work that remain there. And I think it's not clear exactly what that limitation is going to be on for those individuals for certain kinds of things. Like Demetre mentioned, I do think reports on vaccine safety and reports on vaccine recommendations are going to be problematic right now, and I'm not alone in that. There are a whole lot of people that feel the same way. My concern is that I don't want that to be interfering with communications about infant botulism and other kinds of problems where we know that the infrastructure that can be doing those investigations and communicating on it are still in place. At the point at where some reports about things happening in because of unpasteurized milk, if we don't hear about those kinds of things, that's where I know that we'll be in a more difficult place. And so for me, I think it's very helpful that there are groups like what Mike Osterholm's doing in CIDRAP, where they have the possibility of developing some kind of a good housekeeping seal of approval, that if you've got something that's on the website, you can go to a single place or one or two places, and don't expect 300 million Americans to have to do all the research themselves to figure out whether or not something is something that they want to follow or not. That's just not right. Everyone doesn't do their own legal background work and become their own lawyer. There's a reason why there are people that understand the complex science and translate it. And so that trust is, I think, where we're having some trouble right now. Do really appreciate the vaccine integrity project that they have put together. The work they did for the COVID vaccine was great. The work I think they're doing right now for the hepatitis B childhood birth dose, I think, is going to be very important. That is work that the CDC was not able to do, and they are filling in a gap. The ability for them to do this alternative MMWR, the CDC publication coming out through alternative means, I think is a good thing too. We just want to make sure that we don't distribute the work of public health and CDC to so many places that it cannot at some point be available to be reconstituted. And I do think there will be a time when we'll be able to do that.
Yeah, we're going to get to
that. Yeah. And so I'll hand it over to Deb.
Wait, I forgot something. Can I add one? I forgot shouting out CIDRAP is really important, but
I'll
also
allow
like
it.
to shout out two more things that I think are really helpful. So again, these are not like plugs for them, but I find them helpful is sort of like beyond raw data, the analysis. Like I think that your local epidemiologist does a fabulous job of being able to sort of like extract some things into like sort of understandable things. And also it's, I think, still evolving, but, the three of us haven't talked about it, but sort of the pop hive work that's coming.
That's what I was going to say.
Oh, I'll be quiet. Never mind.
For those
I have nothing else to say, Dr. Houry. I have nothing to say.
Just so that our audience knows, your local epidemiologist is a newsletter that's put out by epidemiologist Caitlin Genelita.
Yeah, sorry, I forgot. So I will
that's
say
okay. I just want to throw it out there. Go ahead, Deb.
Never mind.
Demetre and I are saying is Yale has a data system called PopHive, and some of it was originally based off CDC data, like vitals and so forth, but now it's using a lot more of the Epic Cosmos data and some syndromic data. And so they've got a lot of the non-communicable diseases, some of the respiratory dashboards. So I think that's a really nice way to track data. When I was looking at some of the respiratory data recently and CDC staff had been furloughed, that's where I looked, was to Yale Pop High for those updates. So I think the academics are really good at some of these data dashboards, some of the evidence synthesis. Common Health Coalition is also taking what the academics are doing and looking at how you can impact it for payers. So I think they're a nice combined organization. And the regional collaboratives, I think, are really important to look at. There's one in the Northeast, there's one out West, there's some others that are brewing. I hear what Dan's saying, and I want to reiterate that too. These are not to replace a federal public agency. I don't know if CDC will survive, to be quite frank, with what they're doing, but I do think we need a federal public health agency. I view the regional collaboratives as groups that are innovating on top of. So what can you do for your populations? What can you do with data at a level you wouldn't be sharing with the federal government? Yes, I think these are opportunities not just to, I know we're going to talk about rebuilding, but just think differently. As there's some things that I certainly would not be trusting the agency on. I mean, Demetre mentioned the homepage. I think if you look, anything that's going to come out on like autism, potentially reproductive health, even some environmental things, I would have concerns.
Yeah, I'm going to add, like, I would worry about things that are priority populations as well, because I think it's getting worse. So things that are talking about gender identity, things that are like focused on on health equity, the things that you would normally look at CDC, like those are going to start to be things that you should like not. They will be there's concern that they're going to be sort of shifted into an ideology zone as opposed to something that is sort of really helpful. And there will be data loss, and so there's because of some of that, you're not gathering data on some populations. And so I think it's going to be pretty devastating in terms of what we're able to see.
One of our questions comes from Ariel Hart, who actually works at the Atlanta Journal-Constitution. I'm not sure if you guys may have spoken to her. And she said she has readers who tell her that the CDC needed to be more efficient and more responsive to the public. And you guys are saying, hey, these decisions were really impulsive and that wasn't even possible. Do you feel you're able to communicate the import of that and what happened to readers? Like, what are you hearing when you talk to
we were prepared for like 0, 10, 20, even 30% cuts that, I don't think we needed to go that deep, but we were prepared. That would have at least allowed us to preserve some programs that were needed for the public. But instead, like Dan said, it's kind of like, oh, let's just take out this group. Oh, no, because of an admin code, we have to take out an entire division, and it was like, we saw that even with lead. That was one of the secretary's priorities. It was gone. There was an outbreak in Milwaukee that we couldn't respond to, and so that was not strategic. It was not, protecting the public's health. And so there's always ways to be more efficient, but the best way to do that is to allow the staff to engage in those decisions versus having people that aren't familiar guessing, using AI, not listening to others. As we've seen, like they canceled contracts that were needed. Even this most recent, RIF, people that were deployed on Ebola, were laid off. So in my mind, that's not how you're efficient or strategic.
And is the fact that all of this is happening, do you think the public is getting it? Are you like,
no, I don't. No, like
wow.
Both of us did or all three of us did briefings 2 weeks ago with congressional members. Some congressional members weren't aware that we had resigned. And others weren't aware of some of the changes at CDC. I think there's so much going on in the world today that people aren't going to realize until there's that next pandemic or that next health threat, and there will be, and people die. More people die because CDC isn't there to protect them.
Is there more that journalists can be doing to try and get this message out, or are you seeing good coverage and it's just not working? Or what would you advise? Demetre, you're clearly opinion.
Yeah. I mean, I feel like, from the perspective of what I think would be really helpful is sort of journalists, not necessarily just telling the story of like who's gone, but what that means. And so I think that like folks who are like seasoned public health experts, like so Dan, me, Deb, like other people who have been at CDC can tell you exactly what something means and like sort of what the impact is. I'm going to give you like a concrete example, and we'll break some news on this. So everyone listen loud. That the DOJ has decided to remove the primate lab from from HIV. So your question is, what does that mean? Well, that is the lab that does the preclinical work for HIV prevention. And the manufacturers of the drugs, they don't have the primates to do it. NIH doesn't do it. Academics don't do it. So that means that the sort of lab that is responsible for figuring out which agents may be important in preventing HIV by having an animal model that allows you to see if it prevents infections in animals will be no more. And why? Because someone at Doge decided that. For what? I don't know. Like, what does that mean for Americans? Fewer options for HIV prevention. And so all of the new HIV prevention that you're seeing coming out, the sort of 6-month shot, the 2-month shot, those were all things that were sorted out in its preclinical phase in the Division of HIV Prevention's primate lab. So that means people will get HIV.
Yeah,
Period.
I think it does show that the cuts like this, are made kind of willy-nilly. And so if you are with a software company and you make apps, and the apps are for financial, following your bank or whatever, the app's not working. If you fire everybody, you can find other programmers and bring in somebody and disrupt in that fashion. But you don't go into a fire station and just disrupt everything and expect for you to be able to respond to a fire in 2 or 3 hours later. So, I mean, there's a national security component to it. There's also the part about the long-standing science and the expertise in different areas that you can't apply, I think, the just disrupt it and see what comes back next, because a laboratory with primates in it that have been used to figure out how we can actually do long-term prevention for HIV. It's not like there's a whole suite of those that are sitting out there to come in and do it differently. So I think you have to be very cautious about applying some of the principles that are used in software development toward a agency that is a premier scientific agency predominantly filled with specific types of scientists, not just programmers and managers.
If you don't like the computer system flying your plane, right? If you don't like the computer system flying your plane, you don't delete that computer system while the plane's flying. Sorry. Sorry, Dad.
No worries. Just going back to the media part, I want to say, actually, I think the coverage that y'all have done has been great. I mean, after D3 quit, I mean, for like 2 weeks, we were like nonstop, and it was very positive coverage. I thought it was really sounding an alarm. I've realized it hasn't sounded an alarm to all populations because not everybody watches mainstream media. So I think it's how do we get it past that group? And then I was a little snippy. I apologize if that reporter's on today, but like somebody reached out to me yesterday, what's new? And I just said, it's not a matter what's new. It's like tying it back to the continued chaos that has been going on. So I think when there's something that comes up like the measles outbreak or what Demetre just brought up, tying it back to what has happened over the past year or the past 3 months or the past 6 months, because some people don't know what happened, 3 months ago. So I think the more that it can just be brought back to the current state of chaos at CDC and the inability to protect communities from health threats, that it's not getting better, it's continuing to get worse, is what's needed. So every time there's that newsy thing, tie it back to all the disruption.
I do also appreciate the long form pieces that folks have been doing, where they really get into the depths of it. They get to talk to those that are really impacted. They try and explain it too. And I think this is not an easy set of issues to try and just have the general public grasp. So do appreciate the work the journalists have been doing to try and translate that.
A question from Bryn Nelson about mRNA vaccine technology, given what we know its potential is, and not just in vaccines, but I mean, can you talk about the current status of the war? Is there any hope there? Are you seeing pushback from industry or academia on it? What I didn't catch what you said there, Deb.
I said not it. That's a Daniel.
I mean, my personal, I'll let Demetre go in a second, but mRNA, as I was in the flu division for years as a director, that is what we look to. And we had a lot of work being developed for it, because an mRNA vaccine, you don't even have to know what it is that you're going to make as a vaccine. As soon as you know the sequence, you can start making it, in the same type of system that you can make beer in, essentially. I mean, it's that easy, relatively. And so to take that away and just simply say that there might be a problem with it and then stop funding all of the research, $500 million for it, and then fire the person that says that that might not be correct. To me, this is if there is a lasting significant blow to preparedness in the United States, it is because of this. Other countries are likely to keep moving forward. The technology should be continued to be worked on, but you can't grow that much flu vaccine in eggs that quickly. You cannot take every technology and just presume that it's going to work that quickly. Something incredible happened with Operation Warp Speed. We should just own that and keep moving with it.
I mean, I just have very little to add to Dan, which is like sort of going more on from the perspective of like the words that are spoken versus the actions that are taken. So, I think that the mRNA vaccine platform has so much implications for chronic disease. And there is no other platform that has sort of that promise at this point. And so, when you destabilize the trust in science and in science around a platform, you can't pick and choose like who trusts it and who doesn't. You're going to make many people distrust it. And so I think that, this vote of no confidence, the fact that ACIP can present sort of data around COVID-19 mRNA vaccines and talk about that it has an it has like an immunocompromising primer in it. It has, like DNA contamination, like which like, it's all conspiracy, but that is what lands, and it's been lifted. One of the reasons we left, or I left, and together we left, is that the chaos has been lifted from conspiracy into CDC branded presentation, even though CDC is not giving the presentation. So I think that, there are areas where I think the mRNA science persists, but like, I think that the signals are, if you are a vaccine company, how much are you going to invest now in a platform that the government is attacking? I think the answer is not a lot. And that's going to be very problematic.
We've got 8 minutes left. Do you all have a hard stop at okay, because I'm trying to get through everything. Oh, this is a quick one. How can journalists get in touch with other former CDC folks and you guys if they want to get more of this message out?
I mean, we can give you all our emails, or you can find us like on LinkedIn. I'd say
Okay.
we're probably the best conduits, and y'all have been able to find us.
I think they all have our
I feel like they know how to find
Three of us are probably the best
Cool.
conduits to get to other CDC staff, current and past.
Okay.
Yeah.
And then one person made and I want to second this. They made the suggestion that and I think you guys are doing this, but reaching out to the non traditional media, like
We've tried.
Okay, the YouTube folks.
I'm doing a streaming thing tomorrow with Destiny for like over an hour and a half or something.
Awesome. Great.
So like we're trying to do.
We've done lots of podcasts, more to come. Like I think we're all like sort of running in that space as well. And like I think that we're all eventually going to have like other work that's going to make it hard to do it at this tempo. But I think that we're in it to make sure that we keep the drumbeat going on this in traditional and new media.
Yes.
I'm going to wrap together the last 3 questions so you know what's coming. One of the questions is basically just pulling together what several people have asked. Is how do we recover from this? How long is it going to take? What's it going to require? How can it be done? And I want to pair with that what the impact of CDC's losses have been outside of the US. I think a lot of people don't realize how much work the CDC does outside of the US, and it has a budget many times the size of the WHO's budget. And after that, I'm going to ask you for what give us some hope at the very end. But let's talk about what's been lost outside of the US, and can this be reconstituted? How do we recover? How long is it going to take? Is it possible?
Yeah, I can start with that one. So we have lost, for instance, the President's Malaria Initiative, which is a program that was stood up under George Bush, the second president. And it was really, has been doing incredible work. But for whatever reason, when USAID was cut and funds were cut, it is suffering right now. And so from a global standpoint, CDC's engagement in countries, I think, is at risk right now. If we want to get to the hope piece, I can add that there is some ongoing discussion happening right now where there might be some global work that gets reinstated, but we don't know that for sure. But if you look at the budget, that is something where global is just, in many of them, the budget scenarios, it's just removed. And so that will be a very bad thing, because you need to be able to know what's going on overseas, surveillance and monitoring to see about things that are emerging. And you need to be able to send people over quickly to get rid of those things, stop them or mitigate them before they come to the US. And the best way to do that is to have in place CDC staff there. And so anything that risks us being able to know what's going on, have people there, and respond quickly, those are things that will put us at greater risk for these emerging problems that will occur globally.
Deb, you want to take it from there?
I think part of the issue is just with the withdrawal from the World Health, Organization, even if it was separate from budget issues. As Dan and Demetre have said before, we've just had a big loss, like on global pathogens. Certainly, with budget cuts, we're going to lose a lot of capacity in countries. And that you can't build back quickly. And a lot of that's relationships, having those relationships in the country for when you need that quick call or something's going on. But I was going to say, what gives me hope, because you have to have hope, during this time, is the wonderful staff and scientists that still are there at CDC. I told many of the senior leaders when before I was going to leave, that they should all resignation letters, because you always want to leave on your terms. But I said, I hope you all don't leave, though, and I hope that many of the staff still stay. So I think what gives me hope is that there's still a critical mass that are there, and the new public health grads, and clinicians that are out there wanting to continue to do the work on public health with boots on the ground.
So I think from the perspective of global, I think that, there's CDC is a really important thought leader in terms of providing very critical technical assistance to what is happening in countries. So beyond sort of the thing that, thinking about PEPFAR and the things that we do, that CDC does to sort of support the health of folks all around the globe. We also let support governments and other parts of the global sort of universe there, learn from us and use us as sort of as scientific experts to make sure that their labs are better, that their epi is working better, that all of that is, there's even like an international program that approximates the Epidemic Intelligence Service to sort of train people, like I was trained by EIS people for how to actually do applied epi, like an applied public health in the real world. And so I think that, a vacuum created by CDC is going to mean sort of a vacuum globally. I think that, what is that very often CDC would get calls around events in countries before WHO would. And so I think that as you're sort of seeing trust in CDC changing, and also the ability of CDC to work in the field, there's a chilling effect for what ended up being like decades and decades of public health diplomacy that brought us to the place where we're able to sort of look at CDC as an important global player. It is, again, the only agency in health in the US that is both global and domestic. And so it's that important bridge that puts together public health and science in a way that is so critical. And I think I think, the thing that people sometimes don't talk about is that not everything that we do out in the world is altruistic. I think Dan said that. So I think it's important to say that our presence there is, the CDC's presence there is not only about supporting the other people, the health of other countries, but also supporting the information that we need to keep Americans safe in America. And so that's like something that I think we're losing because of the fact that we really haven't made a clear statement that we're still in this game. So like when we pull out of WHO and WHO's funding is going to be even more impacted, like do we even want to be there? And that I think is a signal that's unclear. And then lastly, the hope is the folks at CDC, but also the folks who are on the outside thinking about how to mitigate, to be able to keep looking after the health of people in America and the globe. And so I think, I'm very inspired by the folks who are trying to build toward the Renaissance, even though we're in the middle of the Dark Ages.
Something I just wanted to say about Dan, Demetre, and I, because the three of us can finish each other's sentences and, and agree on like 95% of everything right now. But I think what's important for you all to realize is we're totally different, like different lengths of time, different training, like different backgrounds that led up to it. I think, we have a shared, vision and commitment to science, data, and integrity. And the fact that the three of us are in the same place now, doing what we're doing together, is what should really be the wake up call to all. I mean, we would do this again together, but we came from very different, backgrounds, trainings, experiences.
Yeah.
We have so many amazing other questions that we're not gonna be able to get to. I might email some to you if you guys want to answer them in email later to publish. And we will be posting, by the way, a lot of the resources that have been mentioned during this on the page later. Thank you all so much for joining this. We really appreciate it. You giving us these insights. And we'll figure out a way to share your email addresses where we're not, I don't know if we want to post it on the webpage or not. So
I want to post it on the webpage, but
yeah, that's what I was trying to think of.
Out to you, you can email them.
Yeah, we'll figure out a way to do it.
We don't feel like getting docked.
Yeah, thank you very, very much. We appreciate it. Thank you. And thank you everyone else for joining us today. Just a reminder, this will be recorded and on the Health Journalism website. Everything that was said during this is on the record. And AHCJ will continue to bring you webinars on various health topics as a perk of your membership and for the general public, since anybody can join these. Thank you, everybody.
Bye. Thanks, everybody.